Welcome to everybody who is currently logged in and will be logging in due course. Today we have our Dr. Zubin sir, who actually hosted our first talk also, and he has come back for the 10th episode for one more very interesting topic. That is the role of high resolution manometry as a guiding tool in post poem and post surgical esophagus. Welcome, sir, for accepting our invitation again without any delay and without any hesitation of dates or timings or anything. It just happened so quickly. We are very happy to have you here in this stage. Thank you, sir, for accepting the invitation. The podium is yours, sir.
Thank you, Prashant. Thank you so much. And I remember the first session that we had. I think it was really enjoyable for me also to talk without the time limits and everything and discuss in detail what we really want to. And I'm sure it was well received across India. And subsequent episodes have been really well. So I'm kind of hopeful that even like this one would do the same. And I am thankful to you for having this thing going on for so long now, that it's really a good resource for everybody who wants to learn this topic. So, without wasting much time, I'll just start share my slides. Can you see my slides now?
Yes, sir.
Okay. So stop me in between in case there is some disturbance or some sound not coming, something. I hope everything goes okay. So, to begin with, I think the topic that we have today is slightly different from the normal ones that we all see when we talk of manometry. We'll talk of an esophagus which already has an intervention done, whether it is an endoscopic intervention or it is a surgical intervention. So now there are a lot of issues here that we will discuss subsequently, and we will try to create a protocol, although there is no standardization across the board, but we'll try to create a protocol here where we can use manometry as a guiding tool for our subsequent treatment. So, what are the interventions that you all will see or you all do when you are looking at esophagus per se? The first and the foremost that we all do is poem. We also do balloon dilatations, sometimes for poem or for strictures for that matter. Heller myotomy is something that is very frequently done. But there are a lot of interventions on the surgical side, which we as endoscopists might not be able to do, but we do come across these patients in our daily practice. You will have patients of GERD who had undergone fundoplication. Now you will have patients of GERD who had undergone ARMA, who had undergone GERD-X, who had undergone other variety of modes. You will have patients who had undergone esophagectomies for various indications, whether it is malignancy or stricture or something else. And rapidly, the stomach targeted anti obesity surgeries have also come across a lot. So you have all of these interventions which have, been done or are being done. So something is definitely changing in the esophagus when you do all these things. And you can't just limit manometry as a tool to diagnose eclasia or something else. When you do an ARMA, you are tightening the LES up. When you do a fundoplication, you are tightening the LES up. So something will change. So what we are trying to do here today is trying to analyze these changes and see how we can use them and analyze them on manometry and see what happens if something fails. So this is a standard Chicago, which we all have read, we all have discussed innumerable times across the board. Chicago 4 is the current iteration, Chicago 5 is coming up, but unfortunately, we cannot use them in a post-intervention setting because the basis of these Chicago guidelines is that you patient has not had any foregut intervention in the form in any form, whether it's poem or LHM or something. So we cannot use the standard words that Chicago has given us. So first, I have divided the talk into these 5 different sections. We'll go one by one through each of them, and we will dissect it, to bare threads and what happens when you do these interventions. The first and the most frequent thing troubling us as endoscopists, and I'm sure surgeons also, is eclasia. So I'll talk of eclasia first, and I'll talk of what happens after poem and what happens after Heller's. So the first section is towards post poem. Now, post eclasia intervention or post myotomy, I would say, you have to answer two things: what has happened to the structure of the esophagus, what has happened to the functional status of the esophagus. Remember, it's a functional problem which we are treating in a structural way. So we have to understand that both of them are at a problem in case there is some patient who has not done well. So what happens to the manometric findings? First, in a normal patient who has undergone a myotomy. So these were the three major studies in the literature. Although there have many smaller ones, we have also published from our center, but these were the major ones. What you see here is obviously the IRP will come down once you have done a myotomy. The LES pressure will come down. But what I want you to see is recovery of peristalsis. Across a lot of studies, around 10 to 15% is an average where you will see some peristalsis actually coming back. It has been high to almost at 22%. So a lot of your patients will actually recover peristalsis once you do a myotomy. Second thing people usually ask me, sir, the contractions are just small. They are like 30 Hg of mercury. Are they clinically relevant? So imagine a patient who never had a peristalsis to help him to swallow. Even a small 30 millimeters mercury contraction might actually be clinically useful to do an esophageal clearance or whatever residual food has happened even after a poem. So this small amount of peristalsis is really important. In our study also, when one of my fellows did it, we saw that it's mainly in type 2 and type 3 eclasia. You will not find coming back of peristalsis in type 1 eclasia. Extremely rare. So once we know what this is what normally happens, we have to understand, how do we treat if there is a failure? If IRP has not come down, if LES pressures has not come down, what do we do? So this was the article that we published last year, and we're going to use this as our basis and some other articles to understand what we can do for these set of patients. So the first and the foremost point is how do we define a failure of poem? I think across the board, the what only way you can define is an Eckhart score more than 3 for at least 3 months of a duration post poem or post lap halos also, whether it's a poem or lap, it doesn't matter. Whatever myotomy has happened, the patient's Eckhart score, once it comes down, it goes back up to more than 3, lying for at least 3 months. That should be the defining feature of a failure of a poem. Now, the time periods can be different. You can have a very early failure, that is within the 3 months of the intervention. You can have early failure going between 3 months and 3 years, or you can have very late phases more than 3 years. Why we need to divide them is because usually, there are different reasons for poem to be failing or LHM to be failing within these time frames. In a very early failure, you possibly there's the technical issue, some myotomy is left behind, something to do with the procedure itself. Early failures, when late failures are possibly disease related. When I say disease related, you should understand that poem or lap halos is not curing the patient with an eclasia. We are merely cutting down the muscle to make sure that the symptoms go down. The disease continues to evolve. Imagine this as a DMRD, that the disease modifying drugs that we use for rheumatoid arthritis. We are just changing the natural history of the disease. When we do a poem, we are not really, curing it or curing the patient. So the disease will continue to evolve, although much slowly and possibly in a different way if you don't do a poem. But some of these failures are actually attributed to that. What are the factors? I think first and the foremost, we understand that the pre-procedural factor are if patient already has a sigmoid esophagus, type 1 eclasia, long duration of symptoms, the pre-treatment Eckhart score has been very high. patient has failed, previous treatments for or ecclesia cardia. Intraprocedural, if you had a difficult poem or difficult LHM, you had a lot of mucosal injuries, you had a lot of dissection through the muscles, a lot of fibrosis happening. The length of myotomy on the gastric side was another factor. Earlier, we used to do an empirical myotomy even for a type 3 ecclesia, and now we do more HREM directed myotomy. Experience of the operator, I think that is something which we need to understand, that it's been said around 25 to 30 cases of poem has to be minimum done to to have some level of competence, although there are debates on who will you call an expert. But I think that's something which we all need to understand. Post procedural, I think that's where we will put this talk on, that what happens after the procedure, whether the LES pressures have come down or not, IRP has come down to what extent, whether there's any remnant muscle, and whether the patient has some GERD post poem. Moving on, I think uh, what you see is how do you what tools are with you if you want to diagnose a failure of poem. You have endoscopy, you have barium swallow, you have manometry, and you have endoflip. How do you choose which one to use first? So first and the foremost, I think the ACG still recommends using a timed barium esophagogram, and I will recommend this particular article to everybody who wants to know about timed barium esophagogram. Dr. Uday Kushal sir's very nicely written review article on how to do in JNM. You patient swallows around 200 ml of barium sulfate by 45% by volume, and you keep taking radiographs at 1 minute, 2 minutes, and 5 minutes, and sometimes optionally for even 10 minutes if it's very bad case. You look into the vertical extent of what is your level or what is of the barium column. You also look at the diameter of the esophagus, whether it keeps on increasing. So all these parameters look at timed barium esophagogram. Now, these are some of the examples of timed barium esophagogram which you can see. And these all do correlate with manometry also, and with failures of myotomy post uh, manometry. But what is the problem? Why do we need something more? There's a question is of reliability. The sensitivity is around 75-90%, but the specificity is much less. And what are the questions that we need to answer in a failure patient? We need to look into whether it's an EGJ versus poor peristalsis, which a time varium cannot differentiate. We need to quantify how much EGG dysfunction is there if it is if it's a tight EGG, which again TBE cannot quantify. Symptoms do not correlate well. There was a nice article, which said that even though you will have significant retention of barium in the TBE, but the patients may actually be asymptomatic and the Eckhart score may be even less than 1 or less than 2, you will still, it doesn't really correlate very well with the symptoms. So is it the when it comes to picking up a diagnosis, it's okay. But if you really want to know why it has happened and what to do further, time variant will not be able to help you, because it really cannot give you the answers which you are looking for. So you have to go on, to next test. We want our questions answered. So what does manometry do reliably? It gives you, we want to measure the LES pressure, then I residual EKG measurement very, very well. You want to identify what is the outflow resistance. You want to measure the intrabolus pressures. You want to measure the EKG outflow. It can give you. You want to measure what is happening because of an obstruction, whether the patient still has a compartmental, pressurization or has a PEP. It will give you, and it gives you some prediction of the response. So I think if you compare between HREM and TBE, both are equally good. Both are almost similar costs in India. EJG physiology is given by your manometry. So the answer to your question would be that, okay, I want to know whether my poem is failing because of an EJG or not. That answer can only be given by a good manometry done. Now, once we have defined that we are going to use manometry, and having said that, I do not say that use manometry in isolation. Obviously, they are in such redo cases, you want to have everything. You want to do a manometry, you want to do a time barium, and you want to do an endoscopy. All of them comes together if you really want to solve the problem of a redo cases. Now, in places where endoflip is available, I think currently India has two centers. It's an expensive equipment to use, around 79,000 costs of the catheter. If you can use that, that gives you a really nice idea. And I think internationally, endoflip has been used a lot for redo cases. You can use it intraoperatively also for redo POEM or redo LHM, but the cost and the availability is a problem. Till the time it becomes cheaper and widely available, we have to rely on manometry. So what can manometry do now? Now it gives you whether you want to target the LES if EJG is a problem, or you want to target the esophageal body if your body is a problem. So it tries to give you some guideline. So identify the clinical failure, define it if its START score is more than 3. Perform the manometry to assess the esophagus. And if you're still not convinced, you can do some additional testing. And what will HRM, how do you interpret it? If you have an elevated IRP, that tells you that definitely there is a persistent LES obstruction that is happening. If patient has a normal IRP but absent contractility, is possibly a body failure. So you have to think of a body targeted therapy, maybe a pharmacotherapy, and severely in esophagectomy also. In some cases, I think there have been a case reports of endoscopic plication using a suture device if you have a very large esophagus, and you can keep on doing that for in place of esophagectomy. If you localize a perforation above the EGG, it's possibly a proximal remnant. It's more common in type 3 achalasia, which I'll show you some cases of, to confirm the trial of pharmacological, intervention and possibly perform redo poem in the remnant segment. Wound out LES or blowout myotomy is something which is really a problem. It's more common with lap pellets, less common with achalasia, but happens in type 3 or type 2. It basically is, there is some amount of LES fiber still remaining, which is causing amount of pressure just above the LES, and that causes an over disruption and a blowout. So in these patients, sometimes also you have to do a redo myotomy. The problem here, although, is I have been talking about IRP, elevated IRP, normal IRP. So the whole thing relies on IRP. But in this setting, how will you define what is normal IRP? It can't be 15 because that's for the pre-intervention patients. Here, how will you define IRP? So what do I follow? I look carefully at the EJG because identification of EJG is very, very important for our calculations. So when you are doing a manometry, make sure your placement of your lines are absolutely, correct. Look for artifacts, particularly if you have sigmoid esophagus or doubt of an endoscopy of a stricture. Probably do an endoscopy first, because sometimes those angulation may itself be causing a false sense of a LES, and that will give you a falsely high IRP. Once we have shown that we have placed correctly, this is some of the broad guidelines. So these are not evidence based, but this is what I usually follow. If you have a more than 15, that's definitely of a concern, elevated. That patient possibly has a functional obstruction even after a myotomy. Between 10 to 15, where most of the patients will lie, those are borderline, and you may have to assess clinically and add a time barium esophagogram. Less than 10, we still cannot rule out compartmentalization, but look for things like blowout myotomy, or look for some other issues with the patient which is causing those symptoms. But if you still have an elevated IRP pen, pressurization, that is definitely happening against a resistance. So even if your IRP is 10 or 12 or 13, but you are getting some BEP, look at to that is possibly a resistance at the lower end, whether it may not be as high as what you would expect in a pre-intervention patient. There's also a concept which of delta IRP. We also published for this. Now, what is delta IRP is what they say is that rather than looking at an absolute value of reduction of IRP, look into what percentage has changed. So a delta IRP is a pre-myotomy IRP and a post-myotomy IRP, and it's a more dynamic assessment of LES. So a lot of articles on that. Some said more than delta of more than 10 is gives you a strong correlation with the good outcomes. Even patient with post IRP, delta of 15 had good outcomes. In the good articles by Dr. Moin Kasab, it said that around 8 to 10 delta is a good benchmark for an adequate myotomy. So we also published this, I think 2023 ISDCon, one of my fellows won the award for that. And as Ivy said that at least 30% reduction should be targeted if you really want to be sure and of rather than absolute reduction for adequacy of poem. Now, what happens? Some of these are now cases. So if you see here, you can see this is a patient who had underwent a poem first. You will still see some amount of resistance here, some amount of uh, a segment of muscle left around the upper mid esophagus. This was a type 3 ecclesia, something similar on barium also. So this patient, once we were given some PD5 inhibitors to be sure. So ultimately that muscle relaxed, and now you can see that this patient is now showing almost like a normal post poem findings as you would expect. LES is now okay. There is no pressurization. There is no remnant muscle. So again, in type 3, you can still see same findings. A remnant muscle above, a remnant muscle below, some PEP or compartmental pressurization here. We give him a PD5 inhibitors. The findings completely changed, and we have now he's still on follow up, but we've asked him for a redo entire poem if this does not improve. Next, cause. So we saw the remnant muscle above. Now the remnant muscle is still at the level of LES. So you have a poem done, but possibly left a big muscle trying to, achieve that small gastric myotomy. But this is what it. So I also published in the same thing that pre-operative manometry will tell you the length of the high pressure zone. So which we should not be targeting only 2 centimeter, 2.5 centimeter of gastric myotomy in every case. Look into the manometry beforehand. Look at how thick the zone is, and then decide how much you want to cut on the gastric side. Here again, some muscle is left. Here again, you can see some muscle is left on this side also. And is showing some amount of pressurization. So these cases definitely will require redo of the LES. Now coming on to the body, now you can see in this patient, again post-poem, nothing at the LES, nothing in the body. This patient was type 1 ecclesia, again had symptoms. So this possibly will not, do well, even if you redo the poem again. So this patient will require an body-directed therapy rather than an LES-directed therapy. I'll show you a video of a similar patient. This patient came to me 8 days after a lap hailers, and his symptom was pain. You can look into the esophagus and look into the proximal part is still dilated, and the LES is really open. It's not a problem at the LES level. So this patient had this manometry. As I said, the LES is not a problem, although you can still see an IRP in some of these findings of around 20.8, but these are artifacts because all the fluid is accumulating in the lower part of the esophagus, but endoscopically there is hardly any resistance. So these patients will not do very, very well on redo poem at all. Now, blowout myotomy will something look like this. You will have a remnant LES which is still there, and on a barium you will look these kind of images, which is classical for a blowout myotomy. If you find this LES, please do a do poem on these values. The blowout will at least improve to some extent. Now that's for the ecclesia part. If there is anything, any doubts here, we can have a couple of questions here, or then we'll move on to the post fundoplication manometry. Prashant,
we'll have the questionnaires at the end of the programs.
Okay, fair enough. So coming on to the section 2. Now the next problem is when you have a patient who has undergone a fundoplication. So what happens when we have done a fundoplication? What are the changes on manometry? I have highlighted in the yellow, so I'll not go read the whole detail, but only the yellow part here. If you see the IRP gets elevated because there is a muscle around it now. your LES resting pressure will also subsequently increase. Peristalsis ideally should remain unchanged, but there may be slight increase in the DCI and slight increase in the CFV, which we normally don't read on Chicago, but on CFV is a contraction front velocity. The peristalsis break may still be there. EGG morphology may convert to a type 1 because you have done a RAP. Sometimes you will see some compartmental pressurization, but if there are no symptoms, don't do much. Intrabolus pressure will increase, and this is what actually clinically correlates to. If you have a high intrabolus pressure, high IRP together, they will usually predict an obstructive symptoms in a patient who has post fundoplication. If there are large breaks, and this has to be done in a preoperative setting also, it will tell you, it will predict a dysphagia post this thing. And if IRP is more than 20, it will actually correlate with dysphagia. So these are the expected changes that will happen in a patient who has undergone a fundoplication. How do you prevent post fundoplication problems? Do a preoperative manometry very, very well. If you see this patient has ineffective motility, you did at least tell your surgeons, don't do a complete Nissen's fundoplication in them. Do a two pets or a posterior fundoplication. Leave the anterior part. Okay, this patient will still remain better. Or else they will present something like this. IRP goes up, patient has higher CI. The esophagus is trying to push against a increased resistance at the LES. So intrabolus pressure goes up, DCI goes up, and if it's not able to compensate for the increased LES pressure, patient will have dysphagia. This is a video courtesy of Dr. Sandeep from Ahmedabad. Again, a patient who did not have a preoperative this thing, but the symptoms of dysphagia started immediately after fundoplication. And this video is also includes a post-pharmacological challenge. That means sublingual nifedipine was also given, but still you can see a lot of LES pressures and PEP happening here. So you can see spasms happening in the esophagus. And on the right side, you can see a time medium showing a non-dilated esophagus and showing a significant retention. So this is either a secondary eclasia happening, which has been reported after a tight trap. So these patients will not do well until you remove the or unwrap the muscle at the level of LES. There's something called a gas bloat or a post-Nissen's chest gurgling. Patients underwent a Nissen's for GERD, had developed regurgitation, and he actually tells me that I can hear gurgling in my chest. And this is how it actually looks like. This is not from this patient, but from another patient. You can see that if you do a failed peristalsis happening at this level, there is a pressurization of the bolus, high IBP, and you can see a break here. So this is coming down and breaking through the peristaltic front, and what he hears is a reflux of the bolus here. So that's what he actually hears of. Now coming on to this third part, I think the post-obesity surgeries, what happens? When we have undergone, so there are different kinds of bariatric surgeries which are relevant to us. Most important for us is what is happening in the stomach. So whatever changes will happen in the esophagus would be secondary to what is happening in the stomach. So in the stomach, you can have either a laparoscopic sleeve gastrectomy or you can have a Roux-en-Y gastric bypass. So in a sleeve, the IRP may slightly increase, whereas in a Roux-en-Y it will actually come down. The LES may increase in sleeve similarly. What happens is that the intrabolus pressurization goes to it increases in almost 50% of patients who had undergone a laparoscopic sleeve gastrectomy. That is very, very important. And you will see compartmental pressurization happening. So a LSG, that is laparoscopic sleeve gastrectomy, actually leads to a more changes in the esophagus as compared to a Roux-en-Y gastric bypass. And if you have high IBP, again with high IRP, you can think of a tight sleeve post an ESG, post a lap sleeve. This problem is not there with an ESG because endoscopically we are leaving the fundus open, but it can cause symptoms if there's too much of a tight sleeve because what they're doing with a laparoscopic sleeve is they're just putting in a they don't like suture, they're putting it directly into a stapler, so it actually may cause a much tight sleeve gastrectomy. So how do you interpret this? If you find a patient who comes to you with dysphagia post lap sleeve, look for high IRP, high IBP, and normal peristalsis. It is definitely a tight sleeve, or sometimes there can be a twist on the sleeve also. Absent contractility post Roux-en-Y, it may reflect a long limb bypass, but usually are asymptomatic. Normal IRP with poor peristalsis is again impaired motility, but no outflow resistance. So if you have some specific pressurization patterns, definitely look for sleeve angulations or sleeve stenosis. But I'll show you something very important, something which has been described 5 years ago called as post obesity surgery esophageal dysfunction. It happens very commonly. The common finding is that you have slightly increased IRP but absent peristalsis. So it's a combination of both. Usually I see that these patients haven't had a pre-operative manometry done. So there was infective motility to begin with, and finally they also have post this thing they developed much more worse findings. Subsequently, if you see, let me just go ahead. 1 second. Yeah. So post metabolic surgery, now the question comes whether it's a primary peristalsis problem or a secondary peristalsis also gets affected. So this was a recent article which actually came across, and what they showed was that it's a secondary peristalsis which is actually more, affected, and these patients, even though if they have a normal manometry, they may still have absent contact. Some of them will have poor secondary peristalsis and poor clearance. So these patients will still have problematic in trying to clear the esophagus down. So more amount of reflux symptoms happening post their surgery. Now, what happens in set of patients who have undergone esophageal resections? That is, patients who have undergone esophagectomy for various indications. So IRP and LEH would be gone. So that's not what now you are trying to look at. Look at only the yellow part. The esophageal peristalsis may be absent or low amplitude, and you will expect it. Why you would expect a low DCI is because the LES is a valve, and in an anastomosis is not. So you will not expect a higher DCI in these. In fact, it should come down. Sometimes you will have a compartmental pressurization, and you will, in some of my patients, I have seen PEP kind of thing. So when a PEP happens, so this will happen before an actual stricture forms. So it's actually a response to a slightly increasing pressure at the level of anastomosis. So keep these patients on a very, very close follow-up, particularly if you have patients who have a high intrabolus pressure. So it may actually predict an anastomotic stricture or actually a twist in the site of anastomosis. Rest, I think, are not very, very important. Only the yellow ones, the DCI, the pressurization patterns, and the intrabolus patterns. This is one example. You can see here, this patient underwent the distal esophagectomy for a malignancy at the EJG level, and there was an esophagogastric anastomosis. You can see there is some PEP, some compartmental pressurization happening, even though endoscopically there was no stricture here. But you keep this patient on a follow-up, and right, this patient after 6 months did develop a early stricture which required a dilatation. Again, another image of another patient, some showing something very, very similar. Now we on the last part. I think we should be on time for this. Yeah, last 10, 15 minutes. So this is something which I, enjoy doing it, and I'm finding good, things in this particular setting. We have really increased our esophageal ESTs, all across India. There are a lot of centers who are doing a lot of good EST numbers for early malignancies, or even, like Barrett's or other things. What happens to the esophagus after you have done a submucosal dissection? So I will just try to give a mechanistic explanation. So you have two plexus in the esophagus or for whole GI tract, which we all must have read in our first year of physiology. You have the orbix plexus, you have the mesenus plexus. The orbix plexus lies in the submucosa and the mesenus lies in the muscular part. What are the function of the two? The orbix plexus is like it forms a mesh around the submucosa. So the peristalsis, its main function is to maintain the continuity of of the peristalsis downwards across the board. Whereas the mesenus is the one which actually initiates it and maintains it through the muscle. But when we do an ESD, you are going to cut through the orbix plexus. Practically, we don't see much changes in a lot of various, studies because it's a single tubular organ. It should not affect anything much. Even if there is nothing mechanical, the foot should come down. But if you do a circumferential ESD, as you can see in the first diagram, you will definitely cut through the orbix and you will lose the continuity of the plexus. Whereas if it's not a circumferential ESD, even if you cut through, the rest of the plexus will still compensate for the damaged plexus at one end. So this is the mechanistic explanation why there should be some changes in the motility. We'll see whether actually this is true or not. Just a theory as of now. So what happens? I think the neurostructures affected orbix, and in one good study which also said that the mesenus plexus is also affected because there are neurons which go from the orbix to the mesenus plexus, which contain a lot of important information regarding the peristalsis. So if you're cutting through them, there definitely has to be secondary effect on the mesenus plexus also. Secondly, the esophagus is again, it's a segmental peristalsis structure. You will not have the full esophagus contracting together. It is segmental. One part, then the lower part relaxes, again contraction, again. So it moves the food down. So this will tell you that if you're doing it in a mid zone, you will definitely damage something. And the clinical impact is that if you're doing a circumferential ESD, there is a change in the circumference. The circumferential mucosal defect ratio is much higher, so that is strongly associated with post ESD motility impairment and sometimes dysphagia. So why am I saying all that? Because there is some studies saying so. So this is a good study again. So all of these studies will come from Japan, where the ESD has been going on for many years now. In India, we have just started in probably last few years. So this was in a change in esophageal motility after endoscopic submucosal dissection for a superficial malignancy. Nicely done study. They did a preoperative, manometry. They did an ESD. Then they followed these patients up. They made sure they did not have any strictures. And in 8 weeks, they again checked. So you had 19 patients who had, and they also divided into two groups. Group A1 was where it did not have too much of they did not have a circumferential resection, and group B was basically with a circumferential resection. So look at some of the examples in these series. So this was the remnant, and this is the initial picture on the A part, that is your along with the chromoendoscopy. You can see peristalsis below, which was a nice good DCI you can see here. This was somewhere in between when they had probably a week down the line post here. This some remnant mucosa is still there on the top. It's not a complete circumferential, this thing. And subsequently, when it has completely healed up in the C part. So what has changed? The area where it is showing some narrowing, although this narrowing is not structurally important, the endoscope will pass through this. But on manometry, it will show a pressurization at this area. So definitely a motility change has happened if you have done a circumferential. Now you can argue whether this is clinically important or not. In some it might be, or it might create in the long run. Another case, similar basic, and you will see a pressurization area just above where the EST actually started. Now, if there is a pressurization, there has to be some functional resistance below it. Whether it's endoscopically visible or not, that's a different matter. Another study by Takeda. So again, pre-ESD, they did on the day zero, they did a manometry and a symptomatic interview. So they actually calculated the Eckhart score on these set of patients. Then they did the manometry, and they did the ESD. Subsequently, after confirming that the scar is formed, they again did a Eckhart score and the manometry, 8 weeks probably. Total 74 patients, 42 were resected. So they had 28 patients, again, group A, group B, more than 2/3 circumference and less than 2/3 circumference. So you can see some of the values almost remained the same, except in group B. In group B, you can see the DCI actually went, high up as compared to the preoperative. Look here, the DCI went to 2104 as compared to the preoperative one. CFV, that is the contraction front velocity, also increased, also kind of decreased. So what it tells you that esophagus is now trying to push the food down against that scar that we have created. Images of the same patients you will see here in group A. This was preoperative. This is the postoperative, no major change. Whereas in the circumferential one, you can see definitely a higher DCI. This is the yellow mark is the area where actually the ESD had taken place. So if now imagine a situation where, like with the pre-fundoplication, you have a patient pre-ESD whose DCI is low. So now, and patient's peristaltic reserve is not there. Same way as we check for fundoplication. Imagine they undergone an ESD in the mid body, and it creates a functional resistance. Will your esophagus, be able to push it down through? It might not. You will have dysphagia, even if endoscopically is okay. And as endoscopists will keep on saying, no, everything is fine. Our area is you are free of cancer, but you do have some kind of disease. So my question would eventually be that when you are planning for a circumferential EST, would you want to do a manometry in these set of patients at least to make sure what is happening through the DCI? I'll just go ahead. So last few slides, I think then we can take some questions. What are the possible implications? So avoid circumferential, as obviously that's the first thing, but I'm sure we will all have cases where circumferential might be required. Preserve the nerves. I don't know how we can do it right now because we can't visibly see them, but probably there may be some better dye shutters or imaging or some other magnification which can tell us where to preserve it. And use steroids. But now using steroids, that's another question. Now, as of now, what we are doing is we are using steroids in everybody who undergoes a circumferential EST. So can we think in which patients we need to give them? So what about early detection? So DCI, if we see that it is increasing post ESD, especially when you have done more than 2/3 resection, possibly you're looking at a hypercontractility and dysphagia. And particularly if you're looking at some pressurization patterns, that if it is there, it's a strong predictor of somebody developing dysphagia at 8 weeks. So what do you do? As I said, regarding the steroids, if it's a manometry shows a normal motility, observe, don't give anything. Mildly elevated DCI, consider early dietary modifications or prokinetic therapy. You can see a disordered motility, very high DCI, pressurization patterns. Think of giving injectable steroids or actually not only doing it at the index ESD, but subsequently also 2 weeks, 4 weeks, you can probably give steroids and you can do a preemptive balloon dilatation. If you actually have a compartmental pressurization on the EJG, particularly if the ESD has been done at the level of LES, so you schedule an early endoscopic reassessment and dilate. But if you still have, you may do a flip. So my last slide now. So manometry, as we know, or as we do currently, is only tip of the iceberg. I think we only use it for Chicago diagnosis. It has wide implications as a tool, which goes much beyond ecclesia. Particularly in the post-poem setting, we really need to use it very, very well. And it's our mainstay to understand which patients will need what. Post-intervention, definitely, whatever I'm saying requires more validation. It requires good studies, but I think in India right now, the whole endoscopic ESD work or poem work is towards more amount of structural changes or the outcomes, the current studies. We are not really studying what happens to the motility or the functional part. post-fundoplication and post-bariatric study. Again, as I said at the beginning, we need to involve our surgeons and ask them to refer these patients to us and to really do post ESD. I think a lot needs to be defined, and we need more studies into it. So thank you so much, and we can take questions now.
Great, sir. As usual, fantastic talk. Lot of things have been elucidated. You demystified the entire thing into at least the subheadings possible. Of course, the validation and calibrations and newer things and newer syndromes might come up like post. Many new things ahead in this particular topic. What I personally feel is the need for the day is actually to have a pre-procedure manometry and post-procedure manometry to really understand what's happening, even with respect to validation and calibration too. So wonderfully done, sir. Thank you. And as usual, we have a few questions. You can open the chat box here. Yeah. So Dr. Naveen Kumar has asked, what is the dose of phosphodiesterase 5 inhibitors that we use?
So I usually use sildenafil, and I begin at 25 milligram BD or thrice a day before at least half an hour, 40 minutes before their meals, and depending on the response, I can go increase to around maybe around 50, but not more than that.
Okay. Where exactly? What are the different places where you try using phosphodiesterase inhibitors?
I will use in any muscle which is there, particularly in the type 3 post type 3 ecclesia myotomy, if there is still some muscle left. If patient is non-ecclesia spastic disorders like jackhammer, nutcracker, I use in them. I want to differentiate. So we had a patient like the one I showed you. That patient underwent fundoplication, and we didn't have a pre-operative manometry, so we didn't know whether this was ecclesia to begin with or not. And in patients who undergo lap Heller's myotomy, they usually include a fundoplication. So somebody is having dysphagia after it. You will not know whether it's remnant muscle or it's the wrap which is causing the problems now. So in these patients, I will either use nifedipine or I will use sildenafil. But majorly I will use in jackhammer and in type 3, because that's in these two. If you read the pathogens in those patients, it's actually the nitric oxide which is the main culprit. So PDE inhibitors will work better than channel blockers. And
any role of acoshiamide, sir? Like in some few cases of outflow obstructions.
Acoshiamide, no, I don't think it will work for EJG outflow obstruction much. But if you have a patient who comes to you with the small remnant stomach after a sleeve, possibly in those patients, you may attempt of you adding that. But for either ways, in this setting, it's a pretty weak prokinetic to work for either of the cases.
Sure. So we'll take up the next question. Dr. Chintan has asked, which part to be cut in blowout myotomy?
Very important. I think you have to be really, really thorough with manometry in blowout. Blowout will be a problem. You have to check your manometry thoroughly, endoscopy thoroughly, barium thoroughly. If and only if you have an LES which is still showing some segment, go to the opposite side of the blowout or the previous poem and cut the LES, only the area of resistance. Because the main pathophysiology behind somebody developing a blowout is having a resistance lower down, which is still there. And that's why blowouts happen. If you cut too much, you will have a blowout on the other side eventually, and that will be a big, big problem then.
So more about the pathogenesis of blowout, like why exactly should it happen? Is it incomplete myotomy towards the distal end or incomplete myotomy from the
Most commonly it is incomplete. So usually you need to have resistance, or you need to have pressurization at two places. So when you have a blowout is that, okay, you have pressure above, you have pressure below, and then the in between area blows out. So usually it will be in places where you leave out a muscle below at the LES and something above, or patient develops, let's say a diverticulum somewhere in the above area causing a septum, which is causing the pressure as well as flow. So you need to identify these two areas. You have to cut at least the lower part, if not the upper part. And if you can identify both sets, cut through both. But as I said, it's not an easy condition to treat. it's something which is very, very difficult. So probably refer these patients to, somebody who has already handled them well in the past. Cutting through these set of muscles is not going to be easy.
Okay. So one more question. What I have of late been noticing is the length of myotomies have started reducing because of various reasons. Some of the proctors or experts who are doing poem regularly, initially their lengths were much higher, but of late the myotomy lengths are coming down and they feel the patient is also doing better with lesser complications. Is it true? Or do you feel that no, myotomy is especially important if it is type 3, this, that, some specific indications?
In type 3, there is no doubt. It has to be tailored. You have to tailor a myotomy as per your manometric findings. The question problem comes in type 2 and type 1. In type 2 mainly, type 1 is also that's not a big problem. In type 2, what happens is that not every LES will be same. In fact, in one of my other talks, there's a slide which actually shows you different LES in eclasia patients. Some of them would be 2 centimeters, some of them would be 4, some would be 2.5 or 3. The standard now across the experts is that you do 2.5 centimeters of gastric side myotomy and you go towards the lesser curve. You try to preserve the sling fibers. That's mainly to prevent reflux happening to the set of patients. But you should not be unifying it to all the patients. I think there's still a lot of subjectiveness left behind for individual cases. At best, pre-operatively, you can look into the LES length or the high pressure zone length. As you reach that area endoscopically, you will see that this is the area where my scope is tightening across the narrowing. So make sure that you are cutting 2.5 or whatever the length of the diameter of the LES that is there. And then beyond it, you are cutting maybe another 2 centimeters towards the gastric side. So I think that should be something which should be minimum doing in my opinion. So we also sent a poster to DW last year. We said that LES, HREM directed LES myotomy in any eclasia, whether it's type 3, type 2, or type 1, gives you better outcomes. That's simply because you know that whatever high pressure zone is seeing, you are cutting it through. There will be rarely a case where you will have a hiatus hernia and you will have a eclasia, and in fact, the high pressure zone would be more higher up, and below you will have eclasia. So you will not cut at the level of LES and that. You actually cut at the area where the high pressure zone is. So, that's why you need to really look into manometry pre-operatively to prevent all these things happening later.
Yeah. Next question by Dr. Indu. Kindly explain body-directed and LES-directed therapy.
So that simply means that, okay, that manometry tells you a body-directed means in current terms esophagectomy, but I think there would be some endoscopic answers to it also subsequently. Like I said, now there've been a couple of case reports where they have done a suturing or a esophagoplasty, where they will just reduce the lumen of the esophagus by doing suturing, but it has to be done multiple times. Whereas in LES, that is what we normally do. We do poem, or we do balloon, or we do Botox. All that is LES. So in normal eclasia, we're targeting LES, whether we're doing Botox, balloon, or poem. Whereas body means esophagectomy or maybe esophagoplasty.
Question by Dr. Randip Rana. Will the patient with secondary achalasia showing pan-esophageal pressurizations and spastic changes improve just with myotomy at LES?
No, when you are saying something is secondary eclasia or something pseudo-eclasia, you have to rule the cause out. If it's a malignancy, if it's a tight trap, that has to go. So you can't just cut the muscle. So it's an extensive compression. So imagine, let's say you have a patient who has an esophageal stricture. That stricture can be because of possibly lymph nodes causing a compression at the esophagus or the mucosal itself. You will not, even if you do something to the mucosa or you dilate the mucosa, your lymph nodal compression is still going to be there. Similarly, in a secondary eclasia, if there is something outside the lumen of the esophagus causing that compression, even if you cut through the muscle, it will not improve at all. So in secondary eclasias and pseudoeclasia, that's the most important thing. In fact, this is the one thing we are trying to rule out in almost every eclasia patient before we do a poem in them, whether we are not missing out on a secondary eclasia. I had a patient who had a pseudocyst in the mediastinum causing LES tightening because of leak from a chronic pancreatitis, and he came to us with dysphagia. And manometry, we thought it's a classical eclasia. We in fact started doing poem in that, but as soon as we were injecting, it was not, raising well. So somehow we thought that this like we are not on the right track. We went in the procedure, we went back, did an imaging, and we saw there was a mediastinum pseudocyst, not exactly a eclasia. So things will happen. So really rule out things before you
No,
do
sir,
a point.
I was asking in context with the patient post fundoplication that you were explaining. No?
So in post fundoplication, I think the problem is that you really have to identify that wrap. If there's a tight wrap causing the secondary eclasia, even if you cut the muscle on the endoscopic wall, that means the our esophageal wall, vision will not improve because it's again now it is an extrinsic compression. It's an extrinsic wrap around the esophagus. So if it's very tight until you cut across or like remove it, unwrap it surgically, or nowadays I think Dr. Amol sir has described the procedure endoscopically also. Until you do that, they will not improve.
There can be a chance that patient had similar changes on HREM prior to fundoplication as well.
Absolutely, that's what I'm saying. Pre-operatively, we need to do manometry, and if the case I showed you was exactly the same case where we did not know. We didn't have a pre-operative case, pre-operative HRM, so we didn't know whether it was eclasia to begin with. What happened after fundoplication? But symptoms came after fundoplication. In these patients, you can probably give nifedipine. If it's just the LES, intrinsic muscle, it might improve. Whereas a wrap, although it's a muscular wrap, but it behaves like a mechanical wrap, so it will not improve too much to cause a change on a manometer. So
Okay.
in that patient, if you see, remember the manometry, even though we gave nifedipine, it did not change the findings. So that was actually a tight wrap causing rather than a LES itself.
Next question by Dr. Sanup from Chennai. Why is there pan-esophageal pressurization in secondary achalasia, sir?
So PEP, so see, pressurization is like a response to any, narrowing downstream. It can be a stricture, it can be a peptic stricture for that matter, a LA grade D esophagus, it can be anastomosis is not very tight, or a tight wrap. In all these findings, you will again have some response in the form of PEP. PEP doesn't really, so it's like, the whole esophagus wall is trying to contract in an abnormal way to push the food down. So against any kind of resistance.
Next by Dr. Rangarajan. He has asked fundoplication strategy for IEM type 1 versus type 2.
So so I don't divide them into various types. If I see a TCI of less than 500 in any of those patients, I will upfront call my surgeon and tell them do a 270-degree wrap or a 2 pits wrap. Do not do a full wrap in them. I think that's a clear-cut indication. In fact, some of the surgeons might, get, offended by it, but I write in my report itself that I recommend a partial wrap in these patients.
Dr. Arun has asked, what is the optimal duration between procedure and post-procedure manometry, sir? Is there any such duration?
For eclasia, for a matter of studies, I do at 3 months. But there is, 3 months also gives you a certain predictive value, whether everything is okay at that point of time. And usually these patients will do well. But there are no standard for fundoplication or obesity or ESD. ESD, you have to obviously be sure there's nothing mechanical happening before you do a manometry.
Next question by Dr. Ashish Yadav. Why might a patient have symptomatic dysphagia despite normalized IRP post-poem apart from stricture?
So that was the whole talk, that patient can still have dysphagia post-poem despite normalized IRP. So see, IRP should not be a sacrosanct value. And what is IRP? IRP is just a 4-second window post a swallow where your LES is relaxing well, and food is able to go down. So it's a 4-second minimum pressure at the LES after a swallow within a 10-second time frame. It can be continuous or discontinuous. So IRP doesn't tell you whether what is happening, after you have cut down the muscle. So patients, after you have cut down, you will have a fibrosis of that area. You will have possibly leave some muscle behind in that area. You have not cut through all the muscles. So your IRP, even though will come down from, let's say, 30, 35 to maybe 10 or 12, but patient might still be symptomatic because all the muscles are not cut through. Whatever is remaining is causing that problems. And in patients who had type 2 and type 1 eclasia, the long duration of the illness itself decreases the esophagus ability to push the food down. So even if you have some remaining pressures, you will still have patient will still have dysphagia. An IRP can be normal in that set of patients, but patient will still have retention on barium because the changes already have had taken place in the body of esophagus. So our target is not to bring down IRP less than 15. Our target is to make the Eckhart score less than 1 or less than, or Eckhart score less than 3. So don't look at IRP, look at what has changed and how much Eckhart score is coming down.
Great, sir. I remember one of the cases in one of the papers that you had published, that apart from these routine LES causes or body of esophagus causes, there was one case of neurodysphagia also. After poem, patient developed dysphagia.
Yeah. So yes. So that patient actually came to me with, it was eclasia, we did poem. He, the manometry was okay. Later on, he came back with dysphagia. We again thought that something has happened to the LES or something had happened to the body. So we did a manometry, it was fine. And while I usually have at that time I was trying to create data for like pharyngeal and UES manometry. And while coming back, I was doing a manometry. I did not see any pharyngeal contraction waves down. And then we redid the endoscopy again. And I just looked into the vocal cords and not the endoscopy down. So the vocal cords were not moving. One of them was not moving very well. So that's why we picked up possibly was a 9th, 10th nerve palsy. We then did imaging and all that. We found out a tumor somewhere. So it was possibly a neurogenic, So yes, one of few cases, something will always, it's medicine. It always will bring you surprises.
So you're telling me that in future we'll also have a talk on pharyngeal manometry, maybe?
Sure. We can have that. No problems.
Great. So that's also evolving. Not many centers, I'm not even able to count how many centers are doing a pharyngeal manometry. So of late, I've just started improving my knowledge on fee study, which follow assessment, which is doing this.
No, it's very interesting. It's very one of the most interesting. In fact, once you start doing pharyngeal, you will find it more interesting than the esophagus one.
Kind of, yes, sir. True. Lots to learn also.
Lots to learn that, yeah.
Okay. Great, sir. As usual, we've completed the talk in 1 hour with adequate answering for all the questions which showed up. It was really wonderful having you here to talk on such nuanced topics, and we hope you will join us again and again and again for various such interesting topics. Thank you.
Sure. You're always welcome. Thank you so much for having me. Thank you.
Thank you, sir. And to all the viewers here and who will be logging on to the sessions later in the YouTube channel, I would like to inform you all that INMA of this year, 2025, will be held on August 30th and 31st at Calcutta, organized by Dr. Uday Ghoshal, sir. So you all are welcome to join all of us with similar interests in HRM and neuromotility sciences. Thank you.
Thank you.